Thank you, ma'am.
Hi, Bacho. Good afternoon. Oh, thank you so much. I didn't realize that the class has started. So I think you can now see me and Hi, Bacho. Good afternoon. You can see me and you can hear me properly. Okay. So we begin with important images in midwifery, a very, very important session for your upcoming NORCET exam, right? And in order to, so that, this session is very productive for you, and I also get a lot of energy when you people are there on the comment section and you are making the comment, you're putting the comment section on fire, right? So let's make this session a very, very lively session, a quick session where we revise all the important images related to midwifery. ठीक है? So chalo. Before I begin, I had selected a very nice quote for all of you. Today morning only I read this quote, and this quote was, study hard no matter if it seems impossible, no matter if it takes time, no matter if you have to be up all night. Just remember that the feeling of success is the best thing in the entire world, and I can vouch for that. इतनी मेहनत करने के बाद जो सक्सेस मिलती है ना, that has different level of satisfaction, right? So, and I know all of you are working hard. I know all of you are putting your best foot forward. So, and I know all of you are going to taste that fruit of success. Yes, टाइम सबका अलग अलग हो सकता है. कोई उस सक्सेस को थोड़ा जल्दी टेस्ट करेगा, कोई थोड़ा बाद में टेस्ट करेगा, बट सबका टाइम आएगा. That I can tell you, that I can assure you, that God has made good plans for all of you, right? So let's not disrupt or destroy those plans by not working hard. From our side, we just need to put in those efforts, and you can see what plans God has in store for you, right? So, kare, start with the important images in midwifery, right? So the first question and the first image which is there for you is, identify the sign shown in the image and what time is it elicited. So अपने दिमाग में पहले सोचो कि ये कौन सा sign है, and then answer कि at what time is this sign elicited. Option A 6 to 8 weeks, option B 6 to 10 weeks, option C 8 to 10 weeks, option D 10 to 12 weeks. So first tell me in the comment section, ये sign कौन सा elicit किया जा रहा है? Which sign is being elicited? Excellent, Anvesha. This is Hagar sign, right? And at what time is this sign elicited? True. All of you, excellent, awesome. This is Hagar sign. And what does Hagar sign say? Hagar sign क्यों elicit होता है and क्या होता है Hagar sign? So Hagar sign is based on the principle कि जो यूट्रस में जो प्रोडक्ट ऑफ कंसेप्शन होता है, that is present in the upper part of the uterus. So lower part of the uterus is empty also, and lower part of the uterus is soft also. तो जब हम per manual examination करेंगे, right, that means bimanual examination. Bimanual examination, what does that mean? That means your one hand is per abdominally and one hand is present in vagina. One hand per abdominally present behind the uterus, one hand is in vagina, and both the hand fingers, it feels as if they are touching each other. This is what is called as Hagar sign. Many of you are answering it correctly. Some of you have confusion. Hagar sign is elicited between 6 to 10 weeks. That's the right answer. 6 to 10 weeks pe Hagar sign is elicited. Right, now you are going to tell me Goodell sign. What is Goodell sign? Quickly let's revise the signs in pregnancy. बहुत important है signs in pregnancy. So what is Goodell sign? What is Goodell sign? Goodell sign is softening of the cervix. Very good. That is softening of the cervix. Now, Goodell sign is the first sign to become positive in pregnancy. Quickly tell me कि Goodell sign कब elicit होता है? When can you feel the Goodell sign? At what time can you feel the Goodell sign? In the comment section. Now, Goodell sign. You people are all answering it right, but अब मुझे बताओ at what time is Goodell sign elicited? Excellent, Shobha. It is 6 weeks. 6 weeks. Awesome. All of you, very nice. This is elicited at 6 weeks. Manikanta. Beta, it's not 8 weeks, it is 6 weeks, right? So remember, जितने भी early signs होते हैं, उसमें Goodell sign is elicited the earliest at 6 weeks. Then 6 to 10 के बीच में आता है Hagar sign. And then rest of the signs, जितने भी signs होते हैं, बाकी 8 weeks. बाकी signs कौन कौन से होते हैं? Chadwick sign. So what is Chadwick sign? ये बताओ quickly in the comment section. Then Palmer's sign. What is that? Tell me that. Osiander sign. Quickly tell me what is Osiander sign. And your 𝒆𝒂𝒅𝒔 sign. चलो अब बताओ. Quickly let us revise these signs. 𝒆𝒂𝒅𝒔 you cannot see, it has gone down, so I am writing it here. अब बताओ. Yes, Niranjana, Chadwick sign is bluish discoloration of cervix and vagina. Very good. Excellent. That's bluish discoloration of cervix and vagina. Then what is Palmer's sign? Palmer's sign क्या होता है? हो गया, सबने आंसर कर दिया. आई एम हैप्पी. सुभेंदु ने आंसर किया है Osiander sign. Excellent. Osiander sign is when you can feel pulsations in the lateral fornix of vagina. That is Osiander sign. Payal ने आंसर किया है Palmer's sign. These are painless, regular, rhythmic contractions which are felt in the uterus. Right, so these are painless contractions which are felt in first trimester. Very good. 𝒆𝒂𝒅𝒔 कौन बताएगा? Who's going to tell me the 𝒆𝒂𝒅𝒔 sign? 𝒆𝒂𝒅𝒔 sign, that is asymmetrical enlargement of the uterus. Asymmetrical enlargement. Excellent, Sanguine. Asymmetrical enlargement of the uterus. Awesome. So these are the signs which are seen in first trimester. Now who is going to tell me Hartmann sign क्या होता है? Hartmann sign. Let me see. Who can tell me Hartmann sign? Hartmann sign? हो गए, बाकी सारे signs हो गए बेटा. Now I just want to know Hartmann sign. Pratham, Neha, beta, all of us, we've done 𝒆𝒂𝒅𝒔, that is asymmetrical enlargement of the uterus. मैंने ऊपर लिखा भी हुआ है. So now I just want you to know, to tell me. Excellent. Payal, Itsam, Shobha, excellent. If there is any bleeding at the time of implantation. Bleeding at the time of implantation, that is what is called as Hartmann sign. Tell me what is the other name for Hartmann sign? What is the other name for Hartmann sign? Other name for Hartmann sign? Placental sign. Right? So अगर नहीं मालूम है तो लिख लो, it is placental sign. That's the other name for Hartmann sign. Right? Okay. Now, who is going to tell me what is the pain at the time of ovulation called as? Out of the syllabus question पूछा है. It's not related to pregnancy, but let me see. Pain at the time of ovulation. What is that called as? Pain at the time of ovulation. So अगर कोई भी फीमेल कहती है that there is mid-cycle pain, excellent, it is Michel-Merz syndrome. Michel-Merz syndrome, right. तो अगर कभी भी क्वेश्चन में आए that there is mid-cycle pain, right, that means they are talking about pain at the time of ovulation. Next question is, question आपसे कह रहा है that there is cyclical pain in abdomen every month. There is cyclical pain in abdomen every month. And patient has not yet had menarche. She is a case of primary amenorrhea. So cyclical pain in abdomen every month and she is a case of primary amenorrhea. What is your diagnosis? Cyclical pain हो रहा है every month and patient primary amenorrhea की है. I'm going to show you an image and a question related to it. But first let me see कि केवल इतनी सी लाइन से can my nursing bachas come to a diagnosis? Let me see. Oh Jasmine, I'm so happy beta, you have written cryptomenorrhea. अब इसको थोड़ा सा मुझे बताओ. What reason of cryptomenorrhea? Excellent Toydasri, excellent Anvesha, Payal. This is a case of imperforate hymen. Excellent. Awesome. So let me show you an image-based question which is asked from this. ये देखो. This is a question which can be asked to you. A 16-year-old female visits gynae OPD with complaint of cyclical pain in abdomen and there is no history of menarche, right? So that means she is a case of cryptomenorrhea. Every month she is menstruating, but every month, even after menstruation, the menstrual blood is not coming out, and that is hidden menstruation, and that is what is cryptomenorrhea. The most common cause of cryptomenorrhea is imperforate hymen. अब यहाँ पे जो क्वेश्चन दिया गया है, they are saying local examination shows bulging bluish hymen. Do you see a bulging bluish hymen? Right, now they are asking you, what is the management? What is the management? How are you going to manage this case? I want an answer from all of you very, very quickly. What is the management? D. Excellent. The answer is cruciate incision on the hymen. That's the management. ठीक है, जब भी क्वेश्चन ऐसा आए that there is cyclical pain in abdomen every month and patient को अभी तक menarche नहीं हुई है, young girl है, it means they are talking about imperforate hymen. Now, since the question has come on imperforate hymen, it's very important for us to understand the types of hymen, right? So, types of hymen. In types of hymen, here, look over here. Tell me the various types of hymen which you can see in this image. इसमें से I want all of you to have a look at few of the hymens जिन पे question आता है. So look over here. Tell me what is A, what is B, C, D and E types of hymen. A is a hymen which has been ruptured, right? So this is a hymen which is seen in a female who is multiparous. Right, this is what is seen in a parous female, right? B is, what is B? B is imperforate hymen. C क्या है? C is a normal hymen where you are seeing small opening through which menstrual blood comes out. Virgin females ka hymen. Then this is normal. What is D? What is D? Cribriform hymen. Cribriform hymen. Right? Cribriform hymen means cribriform hymen means sieve-like hymen, channi jaisa hymen, right? What is E? E, septate hymen. Septate hymen, right? So these are various images which they can ask you, and I hope all of you will be able to recognize the types of hymen now. Okay? Now, going to the next image. In next image, I want you to see this image over here. A G2P1 at 12 weeks presents for aneuploidy screening. Her nuchal translucency was measured. So this is an image. They may show you this image beta for nuchal translucency. Now understand, what is nuchal translucency? Nuchal translucency, this is the fluid filled area which is seen below the neck. So this fluid filled area below the neck, that is what is called as nuchal translucency, right? And nuchal translucency, जब आप measure करते हो nuchal translucency, normally how much should be the nuchal translucency? Tell me. Normally, how much should be the nuchal translucency? It should be less than 3 millimeters. If nuchal translucency is more than equal to 3 millimeters, what do you expect? You expect that it can be a case of aneuploidy. That means chromosome number का कोई defect हो सकता है. What can be that chromosome number defect? That could be Down syndrome, which is most common. Then it could be Turner's syndrome, right? इसके अलावा it could be a cardiovascular anomaly in the fetus. A cardiovascular anomaly in the fetus, right? Most common cause is aneuploidy. And क्योंकि most common cause is aneuploidy, my next step has to be karyotyping. And for karyotyping, how am I going to obtain the material? By chorionic villi sampling in first trimester. हमेशा याद रखना, first trimester में you are going to obtain it through chorionic villi sampling, and all of you are giving me the right answers. ठीक है? Now, tell me what is the ideal time for NT scan? Beta, fetal echo is not the right answer. Chorionic villi sampling. अगर chorionic villi sampling में karyotype normal आएगा, then I am going to go for fetal echo. But first I am going to go for karyotyping, and karyotyping के लिए how am I going to obtain the material? Karyotyping आप जब तक fetal tissue नहीं होगा आप नहीं कर सकते ना karyotyping. So for karyotyping I have to obtain fetal tissue, and that fetal tissue is obtained by chorionic villi sampling in first trimester, and second trimester में karyotyping के लिए tissue comes through amniocentesis. We will talk about this just now. So I asked you what is the ideal time for doing NT scan? The ideal time for doing NT scan is 11 to 13 weeks plus 6 days, and all of you are answering it correctly. Very, very good, right? My next question over here. Now look at this image. In this image, what procedure is being done? What procedure is being done in this image over here? In this image, what procedure are we doing? Tell me quickly, what procedure are you doing here? Whenever you get images of procedures, you will have to see कि needle कहाँ पे जा रहा है. Here the needle is going in chorionic villi of the placenta. And because the needle is going in chorionic villi of the placenta, this is chorionic villi sampling. This is, I'll write it properly, chorionic villi sampling. Always look where is the needle entering. Needle यहाँ पे enter कर रहा है into placenta. It is entering into chorionic villi. So what is this procedure? This procedure is chorionic villi sampling. Okay. Now, chorionic villi sampling का time क्या होता है? At what time do you do chorionic villi sampling? You do it between 11 to 13 weeks. Please remember, अगर chorionic villi sampling 10 weeks से पहले कर दी, it is never done before 10 weeks, because if you do it before 10 weeks, it will lead to oromandibular defect, or limb defect. Right? Then, now tell me, what is the most common complication of this procedure? What is the most common complication of this procedure? Most common complication overall for this procedure. Oromandibular defects we've done, limb defects we've done. Now I want you to tell me most common complication of this procedure. Most common complication अगर पूछा जाएगा, it is fetal loss. That means abortion can happen. कितने percentage chances होते हैं abortion के? So if you have done 100 procedures, there will be one abortion. That means 1% chances of fetal loss. ठीक है? Now, I want you to compare it with this image over here. Now, in this question, they are saying at what time is this procedure done? At what time is this procedure done? Tell me, at what time do you do this procedure? Quickly in your comment section. Option A, 8 to 11 weeks. Option B, 16 to 18 weeks. Option C, 18 to 20 weeks. Option D, 22 to 24 weeks. So, Pele, I am very happy that all of you have identified the procedure. Over here in this procedure, the needle is going up till the amniotic fluid. Because the needle is going up till the amniotic fluid, this is amniocentesis. Right? Now, tell me the time at which amniocentesis is done. Amniocentesis can be done any time between 15 to 20 weeks. Best time to do amniocentesis is 16 to 18 weeks. And all of you, please remember that the answer over here is going to be option B. Most of you are answering it correctly. It is option B. Right? Now you tell me, do we do amniocentesis in third trimester? Can I do amniocentesis in third trimester? Can I do amniocentesis in third trimester? Yes or no? Can amniocentesis be done in third trimester? Deepika, I am asking you another question, beta. Can amniocentesis be done in third trimester? Yes, it can be done in third trimester. So, third trimester में जब हम amniocentesis करते हैं, what are the indications? Number one, you can do a therapeutic amniocentesis in case of polyhydramnios. Polyhydramnios, right? तो हम repeated amniocentesis करके polyhydramnios में जो amount of amniotic fluid होता है उसको decrease कर देते हैं. Number two, diagnostic कब करेंगे? Diagnostic amniocentesis third trimester में उसका indication क्या है? If I want to know about fetal lung maturity. जितने भी fetal lung maturity test होते हैं, they are done in third trimester. right? And fetal lung maturity test के लिए भी you need amniotic fluid. You are going to do amniocentesis. So कौन कौन से टेस्ट करोगे fetal lung maturity के लिए? amniocentesis करो, amniotic fluid को निकालो, and इस amniotic fluid में you are going to check lecithin upon sphingomyelin ratio. Lecithin upon sphingomyelin ratio. L stands for lecithin upon sphingomyelin ratio. If this lecithin upon sphingomyelin ratio is less than 2, then that means lungs of the baby are not mature. Lungs not mature. If it is more than equal to 2, that means lungs are mature. Excellent. Now suppose अगर question पूछा जाए, what is the best lung maturity test? What is the best lung maturity test? So most commonly done lung maturity test is lecithin upon sphingomyelin ratio. Now I am asking you, which is the best lung maturity test? Who's going to answer this for me? Best lung maturity test. I am waiting for your answers. Which is the best lung maturity test? Surfactant? Shake test? नहीं. This is not the best lung maturity test. सोचो, Nile blue तो बिल्कुल भी नहीं बेटा. We don't do Nile blue sulfate test these days. Shake test भी outdated है. We don't do shake test these days. Excellent, Shobha. I'm so proud of you, beta. The best lung maturity test is phosphatidylglycerol. Phosphatidylglycerol. You have to check if phosphatidylglycerol is present in amniotic fluid or not. If phosphatidylglycerol is present, lungs of the baby are mature. If phosphatidylglycerol is absent, then lungs of the baby are not mature. Right? Okay? So please remember that the best lung maturity test is phosphatidylglycerol. And how do they ask this question? They will ask you that there is a diabetic female, and in that diabetic female you have to check whether the lungs of the baby are mature or not. So what is the best lung maturity test in a diabetic mother? So चाहे वो diabetic mother पूछे, चाहे वो कोई भी mother पूछे, best lung maturity test is phosphatidylglycerol. Excellent. Now tell me, अब बता दो इसका आंसर. Amniocentesis में fetal loss कितना होता है? You people are so eager to answer that question. कि amniocentesis अगर हम करते हैं, what are the chances of fetal loss? What are the chances of fetal loss when you do amniocentesis? So chorionic villi sampling में when you did 100 procedures, there was 1 pregnancy loss. Amniocentesis में when you perform 200 to 300 procedures, then there is 1 pregnancy loss. That means amniocentesis is much more safer than chorionic villi sampling. Okay, so these are the questions which they can ask you on related to amniocentesis. Ab एक question and then we go ahead. If I find out that the lungs of the baby are not mature, which drug am I going to give in India and what is the dosage of that drug? Which drug am I going to give and what is the dose of that drug? So lungs not mature, tell me the drug and its dosage. Quickly, I am waiting. I know there's some lag, so I'm waiting for your answers. Payal, excellent. It is dexamethasone. June, it is very nice. You've written it very nicely. 6 milligrams dexamethasone. 4 injections you have to give 12 hourly. 6 milligrams, 4 injections 12 hourly. Right. Excellent. All of you, very, very good. Now tell me, Look at this image over here and tell me what procedure is being performed. Look at this procedure and tell me look at this image and tell me what procedure is being performed. So let me see how many of you are going to answer it. अब बताओ quickly से which procedure is being performed. Procedure देखो और बताओ. I have started getting your answers. Excellent, all of you who are answering. So good to see all of you all well prepared for the session. अब यहाँ पे क्या दिख रहा है? The needle is going inside the umbilical cord, right? So this is chordocentesis. Excellent. Chordocentesis. Now, can anyone tell me कि chordocentesis का what is the other name? What is the other name for chordocentesis? What is the other name for chordocentesis? It is PUBS. What do you mean by PUBS? Per umbilical blood sampling. Right? When do you do chordocentesis? Anytime after 18 weeks you can do chordocentesis. But chordocentesis इसमें जो rate of fetal loss होता है, that is nearly 3%. So out of the 100 procedures which I am going to perform, there will be a fetal loss which is going to happen for 3 cases. And that is why I am not going to use it for karyotyping. It is not used for karyotyping. Right? Now, the only indication for doing chordocentesis is in Rh negative isoimmunized patients. In order to know कि fetal hemoglobin कितना है, ठीक है, fetal hemoglobin कितना है ये देखने के लिए, fetal hematocrit कितना है ये देखने के लिए, I do chordocentesis in Rh negative isoimmunized patients. Have you understood beta? Now, in chordocentesis, blood लेंगे कहाँ से? Blood has to be taken from umbilical vein. Another important point is, अगर आप chordocentesis कर रहे हो in Rh isoimmunized patients, then there is no need to give anti-D. If you are doing, I'm writing it here, if you are doing chordocentesis in an Rh isoimmunized patient, then there is no need to give anti-D. I'm writing it properly so that you understand. ठीक है? Remember this. Okay? Now, next. Now look at this procedure. Look at this procedure and tell me what is being done here and in which condition do you do it. ये procedure का नाम क्या है and in which condition do you do it? What is the name of this procedure and when do you do it? Jacintha, you are asking कि why is anti-D not given? Right? देखो बेटा patient already isoimmunized है. Isoimmunized patients में कभी भी anti-D नहीं देते. And क्योंकि chordocentesis करते ही isoimmunized patients के अंदर है, that is why we don't give anti-D. Right? Excellent, all of you. You are telling the right answer for the next question. Next question में what am I seeing? I am seeing this over here is the bladder. This is the uterus. This is rectum. And I am seeing pouch of Douglas. Now I can see that there is a blood-like collection in pouch of Douglas and needle is entering into the pouch of Douglas. So the needle is entering into the pouch of Douglas. That means the procedure which we are doing is culdocentesis. Culdocentesis, right? And when do you do it? Culdocentesis, you do it in case of ruptured ectopic. You do it in case of ruptured ectopic. Now, okay, so I'll explain, Jacinta beta. This is a procedure. See over here, this is the bladder. This over here is uterus. And this is pouch of Douglas. What you are seeing is that the needle is going into pouch of Douglas and whatever fluid collection is there, then you are bringing it out. This procedure is called as culdocentesis. Why it is called as culdocentesis? Because the other name for pouch of Douglas is cul-de-sac, right? So this is what is called as culdocentesis. Culdocentesis is done in ruptured ectopic. Now many of you are asking me that, ma'am, what is colpotomy, right? Colpotomy is a procedure for draining the pelvic abscess. So when you are draining the pelvic abscess, that is what is called as colpotomy, right? Now when I have done culdocentesis, whatever blood has come out, right, I will leave it for 5 minutes. So whatever blood you have withdrawn, right, you are going to leave it for 5 minutes and you are going to see. Acha, Jacinta, I'll explain. Just 1 second, beta. I'll explain why anti-D is not given in Rh negative females isoimmunized. Let me explain this first, right? Now, if the blood which comes out, you are going to leave it for 5 minutes. If it clots, that means your needle had entered into an artery or a vein and this blood has been brought from any vessel. And if it does not clot, then that means there is hemoperitoneum. In other words, there is ectopic pregnancy, right? So how do I come to know whether it is ectopic pregnancy or not? The blood should not clot. Why is the blood not clotting? Why, if it is ruptured ectopic, the blood is not clotting? You tell me. Once the tube ruptures, bleeding happens, and in order to prevent that bleeding from happening, all the clotting factors are going to come and they are going to act so that the bleeding stops. Eventually, these clotting factors will get consumed and there will be bleeding again, right? And now this blood will be devoid of clotting factors because the clotting factors would have been consumed. That is why in ectopic pregnancy, whenever there is hemoperitoneum in the blood, there are no clotting factors. So when you allow it to stand for 5 minutes, the blood will not clot, right? Excellent. Now, I just want, this question over here. So I was telling you that when you are doing culdocentesis in an Rh isoimmunized patient, whenever the patient is isoimmunized, right, already she has antibodies against the Rh antigen. I don't have to give her additional antibodies. When a female is non-isoimmunized, in a non-isoimmunized patient, the anti-D is not there. The antibodies are not there and I have to give antibodies. But isoimmunized simply means that the patient's body has already started forming antibodies. You don't have to give it from outside. Clear to all of you? That why anti-D is not given when you are doing culdocentesis? Because culdocentesis has to be done only in isoimmunized patient. And isoimmunized means already the antibodies are present in a blood. You don't have to give any antibodies from outside. So quickly in the chat box, let me know if you've understood this. I'm waiting for your answers. Jasmine, understood? Good. Now, coming to skin changes in pregnancy. You can get images related to skin changes in pregnancy. Now, image A, image B and image C. What is image A standing for? What is this depicting? Image A. You are seeing a brownish blackish color line which is extending from xiphisternum and going up to pubic symphysis. So what is this? This is linea nigra. Linea nigra. Then comes image B. In image B, I am seeing stretch marks of present pregnancy. Why am I saying this is stretch marks of present pregnancy and not previous pregnancy? Because they are pink in color. Right? So whenever you are getting stretch marks of present pregnancy, it is called as stria gravidarum. Stria gravidarum. Now comes image 3. In image 3, you are seeing hyperpigmentation in the malar area, in the cheeks area of the patient. So this is what is called as cloasma. Cloasma. This is also called as pregnancy mask. Pregnancy mask. Right? Now again, this is reversible after delivery. Now all the skin changes which are happening, see, in pregnancy is a progesterone dominant condition. It's a progesterone dominant condition. That means most of the things which are happening in pregnancy are happening because of hormone progesterone. But these skin changes, they happen due to estrogen. Skin changes in pregnancy are due to estrogen, right? And the other hormone which is responsible is melatonin. So these are responsible for skin changes. Now, coming to important images related to placenta. In placenta, they can show you images of both the sides of placenta, right? So how do you identify which is the fetal side and which is the maternal side? So that side of the placenta where umbilical cord is attached. That side of the placenta where umbilical cord is attached is the fetal side of the placenta. Whereas the maternal side of the placenta does not have any cord attached to it. It is divided into polygonal areas which are called as lobes, and further these lobes are divided into cotyledons or lobules. Right? So let us see about both the sides. The fetal side of the placenta forms 4/5. It originates from chorion frondosum. It is covered by fetal membrane and umbilical cord is attached to its center. When it comes to maternal side, it originates from decidua basalis. It is dull red in color. It has polygonal areas which are called as lobes. Each lobe is further divided into lobules or cotyledon, and the functional unit of the placenta is a cotyledon. Right? Now, a very, very important point which I want all of you to revise is about the placenta. They can ask you number of questions related to placenta. So you have to tell me what are the 3 terms used to describe a human placenta. 3 terms used to describe a human placenta. Three terms used to describe human placenta. Tell me. Discoidal, very good. It is discoidal in shape. It is hemochorial. That means it lies in contact with maternal blood, and it is deciduate. That means, it has to separate after delivery. Placenta has to separate after delivery. Now, what is the weight of placenta at term? 500 grams. What is the ratio of weight of placenta is to fetus at term? 1:6. At what gestational age is weight of placenta equal to weight of fetus? 17 weeks. What is the diameter of the placenta? Diameter of the placenta is 15 to 20 centimeters. It may extend up till 22 centimeters. Right? What is the thickness of placenta at term? I'm getting all of you are putting the chat box on fire. I'm so happy with you people. Thickness of placenta 2.5 to 4 centimeters. Thickness of the placenta at term is 2.5 to 4 centimeters. Clear? Okay. Now, tell me, what are you seeing in this image? What is this happening? What type of insertion are you seeing? And what is the name of the placenta? Tell me quickly. What is the name given to such a placenta? Excellent. This is marginal insertion of cord. We can see that the placenta is attached to the margins of the placenta. Normally the cord is attached to the margins of the placenta. Normally the cord should have been attached to the center of the placenta, and such a placenta is called as battledore placenta. Battledore placenta. Now look at this image and tell me, what are you seeing here? What are you seeing in this image over here? Quickly show me, what are you seeing over here? Identify this condition. Battledore हो गया. अब बताओ next. Yes. Over here, I am seeing that the placenta is divided into two equal parts, nearly two equal parts. So this is placenta bilobata. Placenta bilobata. Why am I not calling it a placenta of twin pregnancy? I am not calling it as a placenta of twin pregnancy because I am getting a single umbilical cord. I am getting a single umbilical cord. Right? Chalo. Now look at this image over here. In this image also, the placenta is divided into two lobes. Here also placenta was divided into two lobes and there were connecting blood vessels in between. But both the lobes were nearly equal. So when placenta is divided into two lobes, which are nearly equal and they have got connecting blood vessels in between, that is what is bilobata. But when you get a placenta which is divided into two parts, in which one part is bigger than the other and there are connecting blood vessels, then that is what is called as placenta 𝒂𝒂𝒅𝒔. Placenta 𝒂𝒂𝒅𝒔. And the small lobe is called as 𝒂𝒂𝒅𝒑ate lobe. Now definitely whenever there is a 𝒂𝒂𝒅𝒑ate lobe, there are high chances that small part of the placenta can be in the lower segment. That is why it can lead to placenta previa, that is antepartum hemorrhage. Then it could also be that the placenta is retained inside the uterus. So it can lead to PPH, right? Retained parts of the placenta or PPH. Okay. Now, Look at this image over here and tell me what is the anomalous thing which you are seeing over here. What is happening in this image? What is this image representing? Again, this is placenta. In this placenta, this is the fetal side of the placenta. This over here is the fetal side of the placenta. And this over here is maternal side of the placenta. If you see in this case, I'll just show it to you with some different color. Yes. So, if you see over here, fetal side of the placenta is small, maternal side of the placenta is big, and it surrounds the fetal side in the form of a ring. That is what is called as circumvallate placenta. Now, a very peculiar thing about circumvallate, I'm writing it here. A very peculiar thing about circumvallate placenta is that this is the fetal side, this is the maternal side. When maternal side is surrounding the fetal side, uske beech mein membranes aa jati hain, and that gives an appearance like a valve, right? So over here is this valve-like structure. So between fetal ring and between fetal side and maternal side, you will get a valve-like structure. So that is circumvallate placenta, right? Okay. Now look at this image and tell me, what is this image showing to you? What is this image showing to you? In this image, what am I seeing? In this image, you are seeing this over here is the placenta. This is the placenta. This over here is the cord. And do you see that the cord has stopped much before the placenta? Right? So the cord has stopped much before the placenta. Right? And the cord is attached to the membranes. In the membranes, the vessels are separating out, and these vessels are directly going and getting attached to the placenta. This is what is called as filamentous insertion of the cord. Filamentous insertion of the cord. Filamentous insertion of the cord may the cord is getting stopped. The cord is stopping much before the placenta. Cord is getting attached to the membranes. Membranes में जाके सारी की सारी blood vessels जो कि cord के अंदर होती हैं, they will separate and they will come and attach to the placenta. This is what is filamentous insertion of the cord, and filamentous insertion of the cord can give rise to a serious situation which is called as vasa previa. In vasa previa, there is fetal blood loss which happens from mother's vagina. So it's not the mother who bleeds in vasa previa, it is fetal blood loss which happens. A question which they ask you on vasa previa is, does vasa previa lead to maternal mortality or perinatal mortality? Vasa previa leads to perinatal mortality. Right? Tell me how many vessels are present in the cord. So initially in intrauterine life, in early intrauterine life, there were 4 vessels in the cord. Gradually only 3 remained. And what are the 3? The 3 which remained are left umbilical artery, left umbilical vein, and right umbilical artery. Right? So these are the vessels which are present in the cord. Now sometimes in umbilical cord you can get a single artery. Now you tell me, is finding a single artery non-significant finding in umbilical cord? Is single umbilical artery presence non-significant or significant? Tell me. If there is a single umbilical artery, normally if there are both umbilical arteries left and right. So if there is a single umbilical artery, what What is that what you are going to interpret? Single umbilical artery hai, so that means there are congenital malformations and there are chromosomal malformations. So जब भी single umbilical artery मिलती है, in case of umbilical cord, you always have to follow it up with investigations to rule out congenital anomalies. राइट पहले कंजेनिटल अनोमलीज को रूल आउट करो बाय डूइंग लेवल 2 स्कैन. अगर कोई कंजेनिटल अनोमली मिले तब कैरियोटाइपिंग करो. सो सिंगल अम्बिलिकल आर्टरी में व्हाट इज द नेक्स्ट स्टेप? नेक्स्ट स्टेप इज यू हैव टू रूल आउट कंजेनिटल अनोमलीज बाय डूइंग लेवल 2 स्कैन. ठीक है. नेक्स्ट क्वेश्चन. While conducting a delivery, you perform the maneuver which is shown below. Following this, there is incomplete separation of the placenta and massive hemorrhage. What is your next step? So first tell me, इस procedure को क्या कहते हैं? Tell me what is this procedure called as? Look at this procedure which is being performed and tell me the name of this procedure. Obviously, the placenta is getting separated, but tell me the name of this procedure. इमेज में मैनुअल रिमूवल दिख रहा है बेटा. इमेज में क्या दिख रहा है? इमेज में दिख रहा है कि विद माय वन हैंड आई एम पुशिंग द यूट्रस अप एंड बैक and with the second hand I am giving steady traction to the cord. This is what is called as controlled cord traction, or this is called as modified Brand-Andrews technique. Modified Brand-Andrews technique, right? Now, in modified Brand-Andrews technique, with your one hand you are going to push the uterus up, right, and back, and with the next hand you are going to give a steady traction to the cord in downward and forward direction, right? So that is controlled cord traction or modified Brand-Andrews technique. So this is a technique for placental removal which has been advocated in active management of third stage of labor. Now the question which they are asking you कि जब हम इस टेक्निक को कर रहे थे the cord breaks, है ना? नहीं, इसमें cord break नहीं दिखाया. इसमें कहा है कि there is incomplete separation of the placenta and massive hemorrhage. What are you going to do? इनकम्प्लीट सेपरेशन है प्लेसेंटा का एंड मैसिव हैमरेज. तो अगर पेशेंट में प्लेसेंटा सेपरेट नहीं हुआ है एंड मैसिव हैमरेज हो रहा है, यू आर नॉट गोइंग टू से कि आई एम गोइंग टू स्टार्ट ऑक्सीटोसिन एंड आई एम गोइंग टू वेट फॉर स्पॉन्टेनियस डिलीवरी. यू आर नॉट गोइंग टू से कि आई एम गोइंग टू डू यूट्राइन मसाज. क्रिडीज मेथड क्या था? ये पहले का मेथड था, आजकल नहीं करते. क्रिडीज मेथड में यू यूज टू स्क्वीज द प्लेसेंटा लाइक दिस. यूट्रस को ऐसे स्क्वीज करते थे ताकि प्लेसेंटा सेपरेट हो जाए और बाहर निकल आए. क्रिडीज मेथड इज नो लॉन्गर डन. नाउ यू हैव टू गो फॉर मैनुअल रिमूवल ऑफ प्लेसेंटा. अगर प्लेसेंटा सेपरेट नहीं हुआ है, partially separated placenta है, take your hand inside the uterus and manually remove the placenta. That is what is called as manual removal of placenta. Manual removal of placenta is done under general anesthesia, right? Okay. Now I want all of you to quickly tell me what are the steps in active management of third stage of labor. कौन से steps करते हो in active management of third stage of labor? Tell me quickly, what are the steps which you do in active management of third stage of labor? Very, very important question. Jaldi batao. Number one, you have to give injection uterotonic to the mother, right? Immediately after the delivery of the baby. Immediately after the delivery of baby. Number one. Number two, what are you going to do? Step number 2. Step number 2, you are going to go for delayed cord clamping. Step number 3, delivery of the placenta by controlled cord traction. Step number 4, intermittent assessment of uterine tone. Intermittent assessment of uterine tone. Please remember, early cord clamping. Early cord clamping is not a part of active management of third stage of labor. Now, delayed cord clamping का क्या मतलब होता है? When you clamp the cord between 1 to 3 minutes, that is delayed cord clamping, right? Now, early cord clamping कौन सी condition में करते हैं? As I told you always, early cord clamping का absolute indication is जब भी आपको neonatal resuscitation करना है, right? And neonate को resuscitate कब करना होगा? If there is birth asphyxia. So this is an absolute indication for early cord clamping. Number 3, if you have RH negative females, then you go for early cord clamping. Number 4, if the baby is a known case of heart disease. If baby is a known case of heart disease. I will write it here. वहाँ पे नहीं दिख रहा ना? So I'll write it here. Number 4, if the baby is a known case of heart disease. ठीक है? Then you go for early cord clamping. Please remember, HIV positive females में या COVID-19 की females में या अगर मैक्रोसोमिया है या प्री टर्म बर्थ है, वो लोग बहुत तरीके से कंफ्यूज करना चाहेंगे क्वेश्चंस में. So in सब cases में you go for delayed cord clamping. Early cord clamping के I want you to remember only these 4 indications. Now, another thing which I want you to remember is intermittent assessment of uterine tone question में दिया हो सकता है. अगर intermittent assessment नहीं दिया है, then the next best answer is uterine massage. Best answer for the 4th step is intermittent assessment of uterine tone, right? But अगर intermittent assessment of uterine tone नहीं दिया है, then the next best answer is uterine massage. Clear to all of you? These are steps in active management of third stage of labor. Active management of third stage of labor is the best method to prevent PPH, right? Now, since we are talking about PPH, I want all of you to look at this over here. What is being done in this procedure, and ये जो instrument use हो रहा है, ये जो catheter use हो रहा है, सबसे पहले तो what is being done. Number 2, ये instrument या ये catheter कौन सा use हो रहा है. Number 3, उसका maximum capacity क्या है. 3 questions. 3 questions. Number 1, what procedure is being done over here? बेटा HIV positive females में delayed cord clamping. Delayed cord clamping. Excellent all of you. This instrument is Buckley balloon catheter. Buckley balloon catheter. Right? And when it is done in PPH. Right, this is balloon tamponade. Balloon tamponade, right? ये procedure को कहते हैं balloon tamponade. And इसमें we are using Buckley balloon catheter and maximum volume कितना होता है इसका? 500 ml. Maximum volume is 500 ml, right? Now there was another question related to PPH image based, which I want all of you to tell me. I want all of you to look at this image over here and identify the suture which has been given. So identify this suture which is being placed over here. Okay. So see here, this suture. The suture which is being, what is the name of the suture which is placed here? Quickly tell me, ये कौन सा suture है? Which suture is this? What is the name of this suture? Anyone? Fiza has answered it correctly. Prajwal has answered it correctly. This is a B-link suture. B-link suture. राइट सो ये suture कहाँ देते हैं? एंटीरो पोस्टीरियरली देते हैं ऑन द यूट्रस, ताकि यूट्रस की एंटीरियर एंड पोस्टीरियर वॉल टाइटन हो जाए एंड द ब्लीडिंग स्टॉप्स. परफेक्ट. नाउ टेल मी, व्हाट इज द ऑर्डर in which the arteries should be ligated to control PPH. The order in which you are ligating the arteries. The order in which the arteries are ligated in a patient of PPH. Quickly tell me that. One, two and three. Batao. I am waiting for your answers. Many times this question has been asked. Jennifer, very good. Uterine artery, ovarian artery, and then uterine artery, ovarian artery, and then अगर इससे भी bleeding ना रुकी, then the anterior division of internal iliac artery. Excellent. Right? So this is the order in which the arteries are ligated in a patient of PPH. Now tell me, what is the drug of choice for a patient of PPH? What is the first drug which you are going to give in a patient of PPH? The first drug which is recommended by WHO is oxytocin. Right, 20 to 40 international units. Now, when you are giving oxytocin, how do you give oxytocin? You give oxytocin as IM injection or as IV infusion. Do you give oxytocin as IV bolus? Never. Never it is given as IV bolus. Why it is not given as IV bolus? Because it can lead to bradycardia and it can lead to heart failure. So that is why it is never used as IV bolus. Now when you are preparing an IV infusion, when you are preparing an IV infusion of oxytocin, in which fluid are you going to prepare that IV infusion? That IV infusion is going to be prepared in ringer lactate ya normal saline. Never in dextrose 5%. Why not in dextrose 5%? Because it can lead to water intoxication. Right? So never in dextrose 5%. Clear? Now my next question. My next question is, अगर oxytocin fail हो गया to control the bleeding, then what drug are you going to give? If oxytocin fails to control the bleeding, then पहले तो oxytocin के साथ और क्या ऐड कर देंगे? Tranexamic acid. अब if oxytocin fails, then I am going to give methergin. If methergin fails, I am going to give carboprost. Right? What is the dose of carboprost which you have to give and maximum how much you can give? What is the dose of carboprost which you have to give and maximum how much you can give? Dose of carboprost and maximum कितना दे सकते हैं carboprost को? Anyone is going to tell me that? I'm waiting for your answers. What is the dose of carboprost which you have to give and how much maximum you can give? 250 micrograms, excellent. Maximum you can give 8 injections, and that is you can give 2 milligrams. Right? 2 milligrams. That's the maximum. Carboprost is contraindicated in asthma patients. Now, इसके साथ साथ में एड ऑन ड्रग कौन सी दी जा सकती है? What is the add-on drug which can be given? Add-on drug which can be given is misoprost. What is the dose of misoprost to treat PPH? What is the dose of misoprost to treat PPH? Tell me. What is the dose of misoprost to treat PPH? Asthma ho gaya Shalini. Now you have to tell me the dose of misoprost to treat PPH. Anjana, carbetocin is not given to treat PPH. It is given in AMTSL. Excellent. WHO says it has to be 800 micrograms. By which route is misoprost never given? By which route is misoprost not given? So it is not given in PPH. So by which route is misoprost never given in a patient of PPH? It is per vaginal. Otherwise, there will be, the drug is going to come out with the bleeding. Right? Now, ACOG says that the dose of misoprost can be anywhere between 600 to 1000 micrograms, and you can give it per rectally also. That is what ACOG is recommending. Clear to all of you? Now, misoprost is contraindicated in previous cesarean section patients. It has nothing to do with cardiac, it has nothing to do with asthma. It is contraindicated in previous cesarean section patients. So that way we've quickly revised PPH. Now look at this question. A woman presents to you at 36 weeks of gestation with complaint of feeling lightheadedness and dizziness when she lies on her back. She says she feels all right if she lies on her side and walks. What is the likely reason for this? What is the likely reason for this? Tell me. When she is saying that when she lies supine or when she lies on her back, she feels lightheadedness and dizziness. When she is lying on her side or when she walks, she feels okay. That means this is happening because of compression of inferior vena cava. There is pressure of the gravid uterus on inferior vena cava, because of which the venous return decreases and because of which the cardiac output decreases, and because cardiac output decrease hoga, mother will feel hypotension and there is going to be lightheadedness. This is called as supine hypotension syndrome. And that is why we tell every female that from third trimester onwards, they should not be lying supine. They should be lying, best is left lateral position, or they can also lie in a right lateral position. Now look at this anomaly over here. And in which condition do you get it? Tell me. In which condition do you get this? What anomaly is seen over here and in which condition do you get it? Edward syndrome. Okay. Anomaly क्या दिख रही है बेटा? I have started getting your answers. So you are confused. This is caudal regression syndrome. Caudal regression syndrome या जिसको sacral agenesis कहते हैं. Caudal regression syndrome या sacral agenesis. Now, caudal regression syndrome या sacral agenesis is seen in diabetic patients. Right? It is seen in babies of diabetic patients. Please remember, congenital malformations, they are not seen in gestational diabetes. Gestational diabetes के patients में you will never get congenital malformation. Number one. Number two, congenital malformation is related to HbA1c. जितना ज्यादा HbA1c होगा उतने ज्यादा चांसेस होंगे congenital malformation के. Next question. What is the most common system which is involved in congenital malformation in babies of diabetic mother? So the most common system which is involved is cardiovascular system followed by central nervous system. If they ask you most common congenital malformation, VSD followed by neural tube defect. What is the most specific congenital malformation? Caudal regression syndrome, जिसको sacral agenesis भी कहते हैं. Caudal regression syndrome या sacral agenesis. Right? Clear to all of you? Now, if they ask you most specific cardiovascular anomaly, so most common anomaly पूछेंगे तो VSD है. मोस्ट कॉमन कार्डियोवैस्कुलर पूछेंगे तो भी VSD है. अब पूछ रहे हैं मोस्ट स्पेसिफिक कार्डियोवैस्कुलर अनोमली seen in babies of diabetic mother. Most specific cardiovascular anomaly seen in babies of diabetic mother is TGA, transposition of the great arteries. Most common is VSD, but most specific is TGA. Overall most specific क्या होता है? Overall most specific ये condition होती है which is called as caudal regression syndrome या sacral agenesis. Clear? Okay. Now look at this step over here and identify the maneuver which is being performed. Identify the maneuver which is being performed. Identify this maneuver which is being performed. Oh, sorry. Over here, I was writing and it got auto-corrected. Mech-Robert. So this is Mech-Roberts maneuver, right? In the option B is Mech-Roberts. Option A is Woodcock-Screw. Option B, Mech-Roberts. Option C, Lofset. Option D, Byrne-Marshall. Right? So this is Mech-Roberts maneuver. Okay? Now tell me what is done in Mech-Roberts maneuver. Mech-Roberts maneuver में for what reason do you do Mech-Roberts? Mech-Roberts is done in shoulder dystocia. It is done in case of shoulder dystocia. Now the question which they ask you is कि shoulder dystocia का management क्या होता है? Please remember, shoulder dystocia का management is step-wise management and वो steps आपको याद रखने हैं because they can ask you any of the steps. right? They can ask you any of the steps and they can say this particular maneuver was done, now tell the next step. So you should be knowing what is the next step, and for that you have to remember the algorithm for the management of shoulder dystocia. The algorithm for the management of shoulder dystocia is HELPERR, helper, where H stands for call for help. So whenever there is I am so happy, yes पूजा शर्मा, बच्चे इतने टैलेंटेड हैं कि उसके अंदर ऑप्शन गलत था तब भी सही आंसर दे रहे थे, दैट इट इज मैक रॉबर्ट्स मैन्यूअर. ट्रू, वेरी गुड. So H stands for call for help, E stands for give liberal episiotomy, right, and empty the bladder. Give liberal episiotomy and empty the bladder. L stands for legs maneuver. And which legs maneuver? This legs maneuver is called as Mac Robert maneuver. What do you do in Mac Roberts maneuver? You flex the thighs and then abduct them. पहले मदर की थाइस को फ्लेक्स करो, पूरा चेस्ट तक लेकर आओ, and then abduct them, right? Then P stands for apply suprapubic pressure. Very, very important. देखो बच्चों, अभी in the FMG exam the question was asked that Mac Roberts maneuver was applied and the shoulders did not get delivered. What is the next step? बच्चों ने next step maximum लोगों ने Woods corkscrew mark कर दिया. But I always tell you कि L के बाद P आता है. So P में क्या करेंगे? हम patient जो हमारे attendants हैं हम उनसे कहेंगे कि सुप्राप्यूबिक मैनूवर लगाओ, सुप्राप्यूबिक प्रेशर लगाओ, मैक रॉबर्ट्स करो, सुप्राप्यूबिक प्रेशर लगाओ, एंड आई एम गोइंग टू डिलीवर दी शोल्डर. सो मैक रॉबर्ट्स पहले अकेले करते हैं. अगर मैक रॉबर्ट्स से शोल्डर डिस्टोशिया रिलीव नहीं होता है तो मैक रॉबर्ट करते हुए हम सुप्राप्यूबिक प्रेशर लगाते हैं. प्लीज अंडरस्टैंड देयर इज अ लॉट ऑफ डिफरेंस between applying suprapubic pressure and fundal pressure. Now, when I say that you have to apply suprapubic pressure, you have to apply pressure from here, above the suprapubic bone. When we say that fundal pressure lagao, to where is the fundus? Fundus is near the umbilicus. So you have to apply pressure from there. So please remember, suprapubic pressure is allowed in case of shoulder dystocia. ये जो होता है ना जिसको आप फंडल प्रेशर कहते हो, फंडल प्रेशर इज कॉन्ट्रा इंडिकेटेड. फंडल प्रेशर कभी नहीं देना. सुप्राप्यूबिक प्रेशर कैन बी गिवन. ठीक है, ओके. देन R stands for, next is R. R stands for remove the posterior arm. So actually I am not removing the posterior arm. What I am doing is, अगर इतना करने पर भी पहले तो E आ जाओ, पहले suprapubic pressure के बाद E. What I am going to do is I am going to take my hand inside and I am going to rotate the shoulder. All of you know कि किसी भी पार्ट ने अगर डिलीवर करना है उस पार्ट को डायरेक्टली बिहाइंड द प्यूबिक सिम्फाइसिस होना चाहिए. So if the shoulders are not getting delivered, in spite of applying suprapubic pressure, in spite of doing Mac Roberts maneuver, I am thinking कि कहीं ऐसा तो नहीं है कि shoulder अभी directly behind pubic symphysis नहीं है. So I will take my hand inside, I will rotate the shoulder ताकि shoulder directly behind pubic symphysis आ जाए. क्योंकि आप shoulder को rotate करते हो, this is called as Woods corkscrew maneuver. Right? Now, Woods corkscrew maneuver करने के बाद what is the next step? अगर अभी भी deliver ना हुआ, then you have to remove the posterior arm. What do you mean by remove the posterior arm? That means अब अपना hand अंदर लेकर जाओ और बेबी के posterior hand को deliver कर दो. That is what is removing the posterior arm means. Literally remove नहीं करना है, deliver करना है. Now अगर उत्ते से भी ना हुआ then क्या करेंगे? Then I will ask the patient to lie on all four limbs. Patient अपने all four limbs पे होगी जो cat and dog like position होती है, and then I am going to try to deliver the shoulder. ठीक है? Okay. What is the most common nerve which is injured during Mac Roberts? What is the most common nerve which is delivered injured during mech Roberts? It is posterior cutaneous nerve of thigh. ठीक. Other important point is fundal pressure is contraindicated. Now, इतना सब कुछ करने के बाद भी HELPERR करने के बाद भी अगर के मान लो बेबी का शोल्डर डिलीवर नहीं हुआ, then what are you going to do? Then you are going to push the head of the baby back into the uterus followed by cesarean section. You will push the head of the baby back into the uterus followed by cesarean section, and that is what is called as, I have written posterior cutaneous nerve. It is lateral cutaneous nerve. All of you are right. Lateral cutaneous nerve of the thigh. Yes. Sorry. It is lateral cutaneous nerve of the thigh. Now, इतना करने के बाद भी अगर head deliver नहीं हुआ, the shoulder deliver नहीं हुआ, so push the head of the baby back into the uterus and do a cesarean section, which is called as Zavanelli's maneuver. Right? Zavanelli's maneuver. Now, if they ask you what is the most common fetal complication of shoulder dystocia, most common fetal complication of shoulder dystocia is Erb's palsy. Right? In Erb's palsy, which nerve roots are injured? C5, C6. Take. Now, most common maternal complication of shoulder dystocia, PPH. PPH. That's the most common maternal complication of shoulder dystocia. So, remember that shoulder dystocia को manage करने के लिए HELPERR helper ये sequence में follow करना है. If then also the shoulders are not getting delivered, then you go for Zavanelli's maneuver, which is the last resort which you have to do. Just 1 second, hold on. Good evening, ma'am. Yes, ma'am. Good evening. Thank you, ma'am. Thank you so much for the invite, ma'am. And ma'am, just now I was on a YouTube session and that is why I was unable to respond. So I have seen that you have shared with me the schedule and ma'am has also shared the flight tickets and everything, the schedule of the flights and everything. I'll just respond, ma'am, just after the session. I will confirm all the things, ma'am. Ji, ma'am, I'll do that. Thank you, ma'am. Okay. Now, next question. What anomaly are you seeing over here? What anomaly are you seeing over here? What anomaly are you seeing over here? Batao, what is this showing you? क्या दिख रहा है यहाँ पे? Anencephaly. Very good. What is being seen? Anencephaly. In anencephaly, the brain is exposed to the external environment. What are the signs which you get in anencephaly? Number 1, you get a shower cap sign. Right? Number 2, they have big bulging eyes. Right? That is frog eye sign. And number 3, they have triangular face. That is Mickey Mouse sign. Right? Mickey Mouse sign, that is triangular face. Right. Now suppose I say a female has come to me with anencephaly at 28 weeks of pregnancy. Right? And I've done an ultrasound, anencephaly is confirmed. What is the next step? Patient 28 weeks पे आई है. Can I do MTP for anencephaly at 28 weeks? Can I do MTP for anencephaly at 28 weeks? Tell me, can I do MTP for anencephaly at 28 weeks? Payal has said yes. Gagan has said yes. Yes. The MTP law, amendment law, which came in 2021 said that in case of severe congenital anomalies, there is no upper limit for doing MTP. And anencephaly is amongst the severe congenital anomalies. So there is no upper limit for doing MTP in anencephaly. My next question. A female has come to you with contraceptive failure. A female has come to you with contraceptive failure. For contraceptive failure, till what time can you do MTP? For contraceptive failure, till what time can you do MTP? For contraceptive failure, कब तक कर सकते हैं MTP? बताओ, contraceptive failure के लिए till what time are you going to do MTP? Till 20 weeks. Right? Rest every cases में 24 for contraceptive failure till 20 weeks. Right. Now, look at this anomaly over here and tell me what it is. Now, look at this anomaly. यहाँ पे क्या दिख रहा है? यहाँ पे we are seeing that there is anencephaly plus there is spina bifida. So, if you are getting anencephaly and spina bifida together, that is called as craniorachis. Craniorachis. Now, what are you going to give to prevent neural tube defect and to prevent recurrence of neural tube defect? So, how much folic acid are you going to give to prevent neural tube defect? To prevent neural tube defect, 400 micrograms per day. To prevent recurrence of neural tube defect, recurrence of neural tube defect का क्या मतलब होता है? Recurrence of neural tube defect का मतलब है कि already एक mother के पास एक baby है with neural tube defect. तो ऐसे केस में the dose which you have to give is 4 milligrams per day. When are you going to start it? To prevent neural tube defect, you are going to start 1 month prior to conception, at least 1 month before conception. And to prevent recurrence, you have to start at least 3 months before conception. Till how long are you going to continue? You should continue it for 3 months after conception in both the cases. 3 months after conception in both the cases. Right? Okay. Now, tell me, you are seeing an image of placenta previa. You have to identify the type of placenta previa in this case. So, option A marginal, option B central, option C partial, option D low-lying. Tell me, option A marginal, option B central, option C partial, option D low-lying. So, which type of placenta previa is this? So, I've started getting your answers. So, over here we can see that the placenta is completely lying over the internal os, and because it is lying completely over the internal os, that is why this is a case of complete placenta previa or central placenta previa, right? Now, they give you images of placenta previa and they ask you to identify which type of placenta previa it is. Now, if the placental edge is coming in the lower uterine segment, placenta lower uterine segment तक आ रहा है, but internal os तक नहीं आ रहा है, right? So that is, it is within 2 centimeters of internal os. Then you call it as type 1 placenta previa, जिसको lateral placenta previa भी कहते हैं. If you are getting placenta coming up till the margins of internal os, so you can see placenta is coming up till the margins of internal os, but it is not covering it, then it is type 2 placenta previa, or it is marginal placenta previa. Now, if placenta is covering the internal os partially, then that is type 3 or partial placenta previa. And if it is covering it completely, then it is type 4 या central placenta previa. Now, please remember that type 1 या lateral placenta previa को low lying placenta भी कहते हैं. You call it also as low lying placenta, right? Now, whenever you have got a placenta previa, management of placenta previa, the delivery which you do in placenta previa is always cesarean section. You always have to do cesarean section in case of placenta previa. Next question which they ask you is, stall worthy sign is positive in which variety of placenta previa? Stall worthy sign positive. So please remember, stall worthy sign is positive in posterior varieties of placenta previa. A posterior variety can be type 1, it can be type 2. तो दोनों type की posterior varieties, whether it is type 1 or whether it is type 2, you are going to get stall worthy sign positive. My next question, what is called as the dangerous variety of placenta previa? What is the dangerous variety of placenta previa? So please remember, type 2 posterior is called as dangerous variety of placenta previa. Right. Now, what are you seeing in this image over here? What are you seeing in this image over here? What is this condition called as, and in which condition it is seen? What is this condition called as, and in which condition do you see this? Look at this image quickly and tell me the answer. What is this condition called as, and in which condition it is seen? This is called as, anyone? This is seen in concealed variety, and this is what type of uterus? Covular uterus. This is covular uterus. Covular uterus का मतलब है there are bruises which are seen on uterus. Where do you get it? You get it in concealed variety of abruptio. In concealed variety of abruptio, right? And please remember, you will never do hysterectomy. For covular uterus, you never do hysterectomy. Fine. Now, what are you seeing over here? This is normal. This is normal. Now, in image 1, you are seeing that the chorionic villi, normally chorionic villi are attached to the endometrium. Chorionic villi is attached to the endometrium, right? The placenta is attached to the endometrium. Now, in image A, I am seeing that the chorionic villi are superficially attached to myometrium. So, in image 1, if it is superficially attached to myometrium, it is called as placenta accreta. If this is image 2, यहाँ पे what you are seeing, chorionic villi are deep inside the endometrium. When chorionic villi are deep inside the myometrium, so inside the myometrium का मतलब this is placenta increta. And in this image, which is image 3, I am seeing that the chorionic villi has reached up till the serosa. Because it has reached up till serosa, that means it is placenta percreta. Now, whether it is increta, accreta or percreta, in all these cases, right? So, I am writing percreta properly so that you can understand this. Now, in all these cases, management is hysterectomy. Placenta, no matter how much you try to remove, placenta cannot be removed. Patient is going to have uncontrollable PPH and you will have to do hysterectomy. Right? Clear to all of you? Now, look at this instrument over here and tell me false statement regarding the instrument shown in the image. False statement regarding the instrument shown in the image. Option A, it doesn't need electricity. Option B, it creates a pressure of 650 millimeters of mercury. Option C, maximum volume 30 ml. Option D, it can be used for MTP up till 12 weeks. So first identify this. What is this instrument called as? I have started getting your answers, but first tell me what is this instrument called as? This is MVA syringe, manual vacuum aspiration syringe. Manual vacuum aspiration syringe की खास बात क्या होती है? It has got two pinch valves. It has got two valves which are present like these, right? And this is used to do MTP. You do MTP using it, right? No electricity is required, right? And this can be used to do MTP up till 12 weeks, right? MVA cannot be done after 12 weeks. Maximum and best done between 9 to 12 weeks. Right? Now, is MVA syringe की capacity is 60 ml. Pressure which is generated is 660 millimeters of mercury. And if 660 is not given, then you are going to say 600 millimeters of mercury. And now, when you are going to use MVA syringe, इसके यहाँ पे you are going to attach a Carman's cannula. Carman's cannula is a plastic cannula like this, right? एंड ये जो कार्मन्स कैनुला का जब भी आप साइज चूज करते हो कार्मन्स कैनुला का, इट शुड कॉरस्पॉन्ड टू द पीरियड ऑफ प्रेगनेंसी. सो अगर आप 10 वीक्स प्रेग्नेंट फीमेल में एमटीपी कर रहे हो, यू आर गोइंग टू चूज 10 नंबर कार्मन्स कैनुला. 12 वीक्स में कर रहे हो तो 12 नंबर कार्मन्स कैनुला. नाउ दिस एमवीए सिरिंज is an alternative to suction evacuation. Normally, between 9 to 12 weeks, the best method is suction evacuation. But suction evacuation के साथ एक problem है that you need a suction machine for doing suction evacuation. In other words, you need electricity for doing suction evacuation. Suction evacuation में क्या करते हैं? We are taking these Carman's cannula. This is attached to a suction machine. And ये suction machine कितना pressure generate करेगी? 600 millimeters of mercury. मैनुअल वैक्यूम एस्पिरेशन में कितना जनरेट होता है? 660. अगर 660 नहीं दिया है देन 600, राइट? पहले इट इज 660. 660 नहीं दिया है देन 600. सक्शन इवैक्यूएशन में इट इज 600, राइट? एज आई टोल्ड यू, Carman's cannula में either you have to take the size of the cannula equal to the period of gestation or you can take one less. Suction evacuation is best done between 9 to 12 weeks, but it can be done up till 16 weeks. Whereas MVA can be done only up till 12 weeks, right? Now, suction evacuation can be done only in places where electricity is available. तो जहाँ जहाँ electricity available नहीं होती है, वहाँ we are going to use the MVA syringe. MVA को आप 16 weeks तक नहीं कर सकते. Suction evacuation को आप 16 weeks तक कर सकते हो, right? Then there is another syringe which is very similar to MVA syringe. इस syringe में you are going to get a single pinch valve. So there is a single pinch valve which is present. इस सिरिंज की कैपेसिटी होती है 50 ml की, राइट? एंड इस सिरिंज को कहते हैं मेंस्ट्रुअल रेगुलेशन सिरिंज. मेंस्ट्रुअल रेगुलेशन प्रोसीजर इज नॉट डन दीज डेज, राइट? पहले करते थे मेंस्ट्रुअल रेगुलेशन, एंड मेंस्ट्रुअल रेगुलेशन में इस सिरिंज को ले जाते थे एंड वी यूज्ड टू सक आउट द प्रोडक्ट ऑफ कंसेप्शन. एंड ये प्रोसीजर करते थे फॉर डूइंग एमटीपी एट लेस देन 6 वीक्स. बट बेटा अब लेस देन 6 वीक्स पे आई हैव अ वेरी गुड ऑप्शन एंड दैट इज मेडिकल अबॉर्शन. That is why menstrual regulation is not done these days. Clear? Now, next I want all of you to see this image. See this image? What procedure is being done in this? What procedure are you doing over here? What procedure are we doing over here? देखो ध्यान से what is being done. Do you see sutures being applied? Sorry. Do you see, just let me open it properly. Okay. Do you see that sutures are being applied in a purse string manner? Right? Now, whenever you are getting sutures which are being पोटली पर्स देखें, पोटली पर्स में जैसे नॉट लगाते हैं ना, दोनों को टाई कर देते हैं, दोनों स्ट्रिंग्स को, ऐसे ही हम इसमें क्या करते हैं, सर्विक्स के अराउंड ऐसे करके नीडल को लेकर जाते हैं एंड फिर टाई कर देते हैं. दिस इज कॉल्ड एज मैकडोनल्ड सर्कलाज. आइडेंटिफाई कैसे करोगे? पर्स स्ट्रिंग स्यूचर से. मैकडोनल्ड सर्कलाज किस केस में करते हैं? दिस इज डन इन केस ऑफ सर्वाइकल इनकॉम्पिटेंस. किस टाइम पे प्रोसीजर करते हैं? दिस प्रोसीजर इज डन बिटवीन 12 to 14 वीक्स. बेटर आंसर 14 वीक्स, राइट? मैक्सिमम इसको कब तक कर सकते हैं? यू कैन मैक्सिमम डू इट टिल 24 वीक्स. जो आप स्यूचर यूज कर रहे हो वो कौन सा यूज कर रहे हो? नॉन अब्सॉर्बेबल स्यूचर. तो जब स्यूचर लगाओगे, व्हेन आर यू गोइंग टू रिमूव द स्यूचर? स्यूचर विल बी रिमूव्ड बाय 37 वीक्स. What are the contraindications for applying the suture? Number one, if there are ruptured membranes. In other words, if there is infection like chorioamnionitis. Number three, if there is intrauterine death of the fetus. Number four, ultrasound में दिख रही है कि there are anomalies in the fetus, right? Then number five, if uterine contractions are present and cervix is dilated to more than 3 centimeters. So if the uterus is dilated, if the uterus is contracting and cervix ka dilatation is more than equal to 3 centimeters. In that case, I do not do this procedure. So if the membranes are ruptured, if there is chorioamnionitis, if there is intrauterine death of the fetus, if on ultrasound you are getting fetal anomalies, or if cervical dilatation is more than 3 centimeters, a relative contraindication is placenta previa. Clear to all of you? Yes? बेटा जेनिफर 36 से 37 वीक्स के बीच में कभी भी खोल सकते हैं आप. उसको कभी भी 36 to 37 के बीच में कभी भी खोल सकते हो, राइट? क्लियर टू ऑल ऑफ यू? Yes, both are the same. McDonald and tightening of os both are same. Anjana, dilatation and evacuation and suction evacuation are different. Suction evacuation is done in first trimester, जो अभी मैंने बताया था, कार्बन स्कैनुला को सक्शन मशीन से अटैच करेंगे. डायलिटेशन एंड इवैक्यूएशन सेकेंड ट्राइमेस्टर में करते हैं, जिसमें आप सर्विक्स को डायलेट करोगे एंड फिर ओवम फॉर्सेप्स को लेकर जाओगे एंड प्रोडक्ट ऑफ कंसेप्शन को बाहर निकालोगे विद द हेल्प ऑफ ओवम फॉर्सेप्स. दैट इज व्हाट इज सक्शन इवैक्यूएशन. Clear to all of you? That is what is dilatation and evacuation when you do with the help of ovum forceps. Yes, understood, Anjana? Suction evacuation mein Karman's cannula is attached to a suction machine. Dilatation and that is done in first trimester generally. Second trimester mein you do dilatation evacuation जिसमें cervix को dilate करते हो, ovum forceps अंदर लेकर जाते हो and you are going to take out the product of conception. Rajendra Kumar, first trimester abortion के बाद you can start at any time. Anytime you can start MTP contraceptive pills after abortion. शिरोडकर सर्कलाज नहीं करते हैं, मोस्ट कॉमनली मैकडोनल्ड सर्कलाज करते हैं. राइट नाउ प्लासेंटा प्रिविया में रिलेटिव कॉन्ट्राइंडिकेशन इसलिए होता है क्योंकि प्लासेंटा नीचे की तरफ है. सो मेनी टाइम्स इट कुड बी कि ब्लीडिंग स्टार्ट हो जाए पेशेंट को जब आप ये प्रोसीजर करो. राइट नाउ आई वॉन्ट यू टू सी दिस वन. Identify this ultrasound of the uterus. What is this appearance called as and ये किस में मिलती है? What is this appearance called as and ये किस में मिलती है? बेटा PDF I will upload in Midwifery channels Telegram group. Midwifery Madam's Telegram group. So what is this ultrasound showing? This ultrasound is showing you snowstorm appearance. What is this called as? Snowstorm appearance. Right? And this is seen in high datiform mole या molar pregnancy. So option में या तो molar pregnancy लिखा होगा या high datiform mole लिखा होगा. Right? Please remember, a patient of high datiform mole कैसे present करेगा? Period of gestation will be more than the height of uterus will be more than the period of gestation. Right? There will be excessive vomiting. Beta HCG levels will be high. Patient can have PIH. Patient can have thyroid storm. When you see the ovary, in the ovary you will get bilateral theca lutein cyst. Right? So that is how a patient of molar pregnancy presents to you. Tell me that in case of choriocarcinoma which has metastasized to the lungs, again you get a snowstorm appearance. But please remember, choriocarcinoma which has metastasized to the lungs, you get snowstorm appearance on chest X-ray. Right? And that is not the most common appearance. The most common appearance on chest X-ray is cannonball appearance. So अगर कोई पूछे कि कोरियोकार्सिनोमा की लंग मेटास्टेसिस हुई है, एक्सरे में कौन सी अपीयरेंस मिलेगी, डोंट से इमीडिएटली इट्स snowstorm appearance. The most common appearance is cannonball appearance. इस क्वेश्चन में I want to point out to you कि हम नॉर्मली पढ़ते हैं कि मोलर प्रेगनेंसी में मिलती है snowstorm appearance. बट प्लीज रिमेंबर, अगर कंप्लीट मोल एंड पार्शियल मोल में कोई एक आंसर चूज करना हो तो ऑलवेज द बेस्ट आंसर इज कंप्लीट मोल. एंड कंप्लीट मोल का नाम होता है दूसरा हाई डेटिफॉर्म मोल. राइट? So either in the options it will be written as complete mole, or it will be written as high datiform mole, or it will be written as vesicular mole. So mark the answer as complete mole, high datiform mole या vesicular mole. The partial mole में you don't get a snowstorm appearance. Clear to all of you? Yes. So I want to end this session here only. 7 o'clock pe I have another session with you people where we are going to discuss important images related to labor and some important instruments which I want all of you to know before you give your exam. So see you at 7 o'clock with yet another image based session and instrument session. Take care. The PDF of this session, I am going to make it available at the Midwifery Madam's Telegram channel group. Right? See you all at 7. I think my next session will be at 7. Yeah, that is at 7 o'clock. Okay. On YouTube of NNL only.